Okay, imagine stepping into an emergency room. You know, a place defined by urgency, complex human needs, and, let's be honest, often what feels like organized chaos.
High stakes.
Exactly. Now, what if you were told that the very strategies used to streamline, say, a high-efficiency factory could dramatically improve patient care right there?
It sounds a bit counterintuitive, doesn't it? Factory floor meets patient care.
Right. Seems like an unusual pairing. But that's exactly what we're diving into today.
Okay.
Our mission is to explore how a large public hospital emergency department successfully applied lean methodologies. These principles, usually rooted in manufacturing, to enhance both patient care and operational efficiency.
So digging into how they actually did it.
Yeah, we'll unpack the systematic approach they took, the remarkable results they achieved, and the crucial insights gained. Especially interesting given their role as a safety net hospital.
Right, that adds another layer of complexity.
Definitely. And our insights for this deep dive come from a really compelling study. A structured approach to transforming a large public hospital emergency department via lean methodologies. Quite a title, huh?
Yeah, academic titles for you.
Well,
But packed with good stuff, I bet.
it is. Authors are Trushar Naik, Yves Duroseau, Shahriar Zehtabchi, Stephan Rinnert, Rosamond Payne, Michele McKenzie, and Eric Legome. So let's zoom in on why this kind of transformation is so critical right now.
Okay.
Our emergency departments are really at the front lines of a growing national healthcare challenge. What are some of those key pressures making their work so incredibly difficult?
Well, you've really hit on a crucial point there. The study highlights kind of a perfect storm of factors.
Okay.
We're seeing patient visits continually on the rise, the trend researchers pointed to years ago.
Right. Not a new problem.
Not at all. But it's not just more patients. They're often sicker, arriving with higher acuity conditions.
More complex cases.
Exactly. Then you layer onto that the demographic shift and aging populace, which naturally increases demand for medical services.
Makes sense.
And you've got a system under immense strain. What makes it even more complex, though, is the constant financial squeeze from declining reimbursement rates.
The money side.
Yeah, something healthcare providers have grappled with for, decades now.
So it's not just an immediate crisis, but like a long-term systemic challenge that's been building for a while.
Precisely.
This pressure sounds like it really necessitates looking at operations in completely new ways.
Absolutely. And that's where an idea that, initially seems quite industrial comes into play.
Okay.
Earlier research actually conceptualized ED operations through an input-throughput-output model.
Input-throughput-output, like a pipeline.
Kind of, yeah. Think of it like that.
Yeah.
Patients come in, input, they move through various stages of care, throughput, and then they're discharged output.
I see.
This way of thinking sort of laid the groundwork for considering how improvement philosophies from manufacturing, like lean, might actually apply to patient flow.
So taking factory ideas to the ED.
It's about recognizing that even a dynamic environment like an ED has sequential processes, and those processes can be optimized.
Which brings us squarely to lean methodology. The study proposes it as a powerful framework for this kind of overhaul. At its core, lean isn't just a set of tools, is it? What truly defines the philosophy behind it?
Exactly. That's a great point. It's a philosophy first and foremost. It's a structured problem-solving system that aims to bring leaders and staff together to continuously improve productivity, efficiency, and quality.
Continuously improve.
Yeah, and all centered on delivering value to the customer, who in this case is the patient.
Okay, patient value.
It's really about creating flow and reducing anything that doesn't serve that ultimate goal, getting rid of the waste.
That's a great distinction. So what are some of the absolute core principles driving this? Principles that might sound industrial but are maybe quite intuitive in practice.
Well, the first and maybe the most intuitive one is continuous improvement. It's called Kaizen in lean terms.
Kaizen.
Yeah, it's this relentless pursuit of perfection. The idea that you never really settle, you're always looking for a better way.
Always improving. Got it.
Then there's a really big one, eliminating waste, known as MUDA.
MUDA. That sounds very direct.
It is.
So
Yeah.
anything that doesn't add value to the patient experience is basically waste. Can you give us an example of what that might look like in an ED?
Precisely.
Yeah.
I mean, think about it. Excessive waiting, right? Waiting for a bed,
Yeah.
waiting for a diagnostic test.
We've all been there.
Yeah. Or unnecessary processing steps, like filling out the same form multiple times. Wasted motion. Maybe staff having to walk long distances for supplies that aren't nearby. Or even defects like misdiagnoses or having to redo tests. Basically, if it's not directly helping the patient get better or move through the system efficiently, it's NUDA, it's waste.
Imagine a nurse walking like the length of a football field during a shift just to grab supplies that should be right there.
Exactly. That's META directly taking away time and energy from actual patient care.
That makes it so tangible. What other principles are central to Lean?
Okay, another core principle is to achieve a smooth, continuous workflow. That's called Hijinka.
Hijinka, smooth flow.
Right. It's about consistency and predictability, trying to avoid those big peaks and valleys in activity. You also want to create error-proof processes or poka-yoke.
Poka-yoke, error-proofing.
Yeah, designing systems so they catch mistakes before they happen, or ideally, prevent them entirely. Think forcing functions, checklists.
Okay.
And crucially, it's about empowering staff, which is known as jidoka.
Jidoka, staff empowerment.
Yeah, this means giving the frontline staff, the people doing the work, the ability to identify defects and even halt the system if something's going wrong, trusting their expertise.
That sounds huge.
It is. And beyond these, Lean also emphasizes deep respect for people, shared responsibility, and that fundamental idea that the customer truly defines what value actually means.
It's clear these aren't just abstract concepts. They're really universal principles for optimizing any complex system, right? Whether it's making cars or treating patients.
Absolutely. Identifying what truly adds value to a patient's care journey and then systematically eliminating everything else. That's incredibly powerful.
So how do they actually put these principles into action? What are some of the key tools they use?
Okay, so to translate these principles into tangible action, the study highlights several core Lean tools. One is A3 thinking.
A3, like the paper size.
Exactly. It's a structured problem-solving method. The idea is you distill a problem, the analysis, the proposed solution, the action plan, everything onto a single A3-size paper. It forces clarity, builds consensus, and makes communication really concise. It's a powerful way to get everyone, on the same page.
I can see how that would cut through a lot of the usual meeting noise and complexity. What else did they use?
Then you have value stream analysis, or VSA.
VSA.
This is a method to meticulously map out all the activities involved in delivering a specific service, like the entire patient journey through the ED.
Mapping the whole thing.
Yeah, identifying every single step.
Brilliant.
Which ones add value, which ones are wasteful. It gives you this visual blueprint, essentially, showing exactly where the bottlenecks and the waste are hiding.
Okay, that sounds intensive.
It is.
Yeah.
And building on that, you have rapid improvement events, or RIs. These are really intensive team-based workshops, often lasting a full week. They're hyper-focused on quickly analyzing one specific process, brainstorming solutions, and then this is key, immediately testing new workflows.
Immediately. Wow.
Yeah, that's what rapid iteration and really hands-on problem solving. Less talk, more action.
I like the sound of that. And the last tool.
And finally, standard work. This is about establishing an agreed-upon best-known way to perform tasks consistently.
Like a standard operating procedure, but maybe more dynamic?
Kinda, yeah. It ensures predictable and reproducible outcomes, reduces variation, and provides a baseline for future improvement. If everyone does the task the agreed best way, it's easier to spot problems and improve further.
Okay, so A3, VSA, RIEs, and standard work. Got it. Now let's turn our attention to the specific case study here. We're talking about a safety net, regional trauma center, and teaching hospital in a New York City borough.
Right, a big, busy place.
Huge. It sees over 130,000 patients annually. And what really makes its role so crucial for the community is its patient demographics. Nearly half are self-pay and another 40% rely on Medicare or Medicaid.
So truly a safety net provider, serving a vulnerable population.
Absolutely, which underscores its vital function. Now, this particular Lean program, it was part of a larger network-wide improvement initiative. They partnered with a specialized Lean consulting firm, Simpler, and their local program was called Breakthrough.
Breakthrough. Okay.
The ED's transformation officially kicked off in October 2009. And importantly, the hospital had already established these overarching True North metrics.
True North, like guiding principles.
Exactly. Big picture goals around things like human development, quality and safety, access and timeliness, cost, growth.
So a balanced scorecard kind of idea.
Yeah. And within that framework, the ED was identified as a key value driver, basically a really important area impacting those big goals.
Which made it a prime candidate for this intensive Lean intervention.
Precisely.
So it's one thing to understand the principles and tools like we just discussed, but how do you actually apply them systematically in such a dynamic, often chaotic environment like an ED.
Yeah, that's the million-dollar question, isn't it?
Right. The study really provides a detailed roadmap. It shows it's not just about having good ideas, but about really meticulous planning and execution, starting right from the top.
And they certainly seem to go about it systematically. It started with executive vision and planning. A hospital executive lean steering committee pinpointed the ED as a priority, specifically because of its big impact on those true north metrics you mentioned.
That top-level buy-in sounds absolutely essential.
You think?
Oh, definitely. Executive commitment wasn't just like a sign-off on a piece of paper.
Yeah.
It was visible, active participation.
So the bosses were actually involved.
Yeah, and that signals to every level of staff that this isn't just another fleeting initiative.
Yeah.
It's a fundamental shift the leadership is personally invested in.
Right. Creates a different energy.
It creates psychological safety, practical space.
Yeah.
It allows real change to actually take root.
Okay, so with that high-level support locked in, the next step was ED vision and planning. A departmental ED lean steering committee was formed.
So bringing it down to the department level.
Exactly. Comprising key leadership within the ED, other stakeholders, even finance was involved, and they were all trained in lean. This committee was tasked with overseeing the whole program within the ED.
Makes sense. Local ownership.
Yeah. And from there, they launched into that value stream analysis, the VSA we talked about. Can you tell us a bit more about what that initial VSA looked like?
Sure. So the ED steering committee, along with hospital leadership and administrators from key ancillary services like lab, radiology, they participated in an initial 3-day VSA.
3 days just mapping.
Yep. They meticulously mapped out the current state, how patients actually flowed through the ED. Then they identified the significant gaps, the major deficiencies, the sources of waste and delay.
Okay. Seeing the problems clearly.
Right. And from that, they collectively envisioned a target future state. What could it look like? What should it look like?
So a vision for improvement.
Exactly. And this whole comprehensive analysis was foundational. It then directly guided the sequencing of all the subsequent rapid improvement events, the RIEs.
Ah, so it told them what REs to run and in what order.
Precisely. Ensuring they tackled problems in a logical sequence to maximize the impact on the patient journey.
So the VSA really set the stage for these rapid improvement events, RIEs, which became the engine of the change. These weren't just like boring meetings, were they? What did an RIE typically involve?
Oh, far from it. These were intensive, really hands-on workshops held monthly. Each RI involved a team of maybe 8 to 12 frontline staff, doctors, nurses, techs, clerks.
The people actually doing the work.
Absolutely essential. And crucially, they also included fresh eyes, people from outside the direct process being looked at.
Fresh eyes. Why?
To bring new perspectives, challenge assumptions, ask the why do we do it that way? Questions that insiders might not even think to ask anymore.
Ah, I see. Smart.
And these events were carefully sequenced, like we said, to emulate the patient's experience as they received care.
So following the patient's path.
Exactly. Meaning they'd redesign, say, login and triage before moving on to redesigning the main treatment area flow. It had to make sense sequentially.
Logical. And the goal.
The clear objective was always to remove those wasteful processes and procedures that the patient would not perceive as value added. Always back to patient value.
That focus on the patient's perspective really seems key. The study gives some really vivid examples of how these RIEs transform specific processes. Can you share a couple that particularly stand out?
Yeah, definitely. One of the most impactful areas was registration and triage.
Hey, the very beginning of the visit.
Right. It went from being this multi-step, often sequential process where patients might get bounced back to the waiting room multiple times.
Frustrating.
Totally. It transformed into a streamlined, single-location team registration and triage. Imagine the difference that makes for a patient who's already feeling sick or anxious.
Huge difference. What else?
Another really significant change was in radiologic exams, getting x-rays, CT scans, etc.
Always a potential bottleneck.
For sure. They shifted from a push model, where ED staff basically just sent patients over to radiology whenever, to a pull model.
Pull model.
Yeah, where radiology staff actively retrieved patients from the ED when they were ready for them. This even included reassigning dedicated staff specifically for ED patient transport.
So radiology took ownership of getting the patient.
Exactly, which cut down significantly on patient waiting times and just unnecessary movement back and forth.
Those are really concrete examples of waste elimination. What else did they tackle with these RIEs?
Oh, lots. They also overhauled charge nurse and patient flow. They replaced cumbersome paper-based patient tracking with an existing computerized system that maybe wasn't being fully utilized.
Moving to digital.
Right. And functions like patient call-in and bed check-in, which used to fall sometimes to the treating physicians.
Taking up doctor time.
Exactly. Those were transitioned to nursing staff, supported by a newly created patient flow coordinator position.
Freeing up the doctor.
Yep, letting them focus on medical care. Another major win was introducing a mid-level provider in triage, like a physician assistant or nurse practitioner.
Okay, what did they do?
They instituted protocol-based order sets right there, post-triage. So for common complaints, they could get the initial workup started immediately.
Speeding things up right away.
Massively.
Yeah.
And it also allowed for much faster disposition of the less complex treat and release patients, got them diagnosed, treated, and home faster, which helps decongest the whole ED.
Makes sense. Any other examples?
Yeah, a few others mentioned were things like consolidating supplies, standardizing how treatment rooms were stocked so everything was always in the same place, creating a dedicated phlebotomy queue for blood draws, and redesigning the whole admissions bed request process, all aimed at chipping away at those non-value added steps.
What really stands out here is that relentless focus on the patient's journey, like you said, and also the empowerment of staff. They weren't just identifying problems, they were actively part of designing and implementing the solutions.
That's absolutely fundamental to true lean transformation, yeah. It's not something done to the staff, it's done by and with the staff.
And you also mentioned how goals were aligned.
Right, that was another smart piece. The ED's departmental targets were specifically designed to contribute directly to the hospital's overall True North targets.
Can you give an example?
Sure. Like, the ED might set a goal for a 20% decrease in the time from when patient walks in to when they're actually seen by a provider.
Okay.
And that would directly support the hospital's overall goal of achieving a 20% improvement in timeliness across the board.
So everyone's pulling in the same direction.
Exactly. That kind of synchronized effort is incredibly powerful. It avoids situations where departments might optimize their own area, but actually make things worse downstream.
All right, so they did all this work, the VSA, the RIEs, standard work. What was the actual tangible impact? The numbers you mentioned are quite compelling.
They really are. And, it's worth remembering this was an exploratory study, right? So we can't definitively say A caused B with absolute certainty.
Yeah, a control group, yeah.
Right. But the data certainly paint a very persuasive picture. And what makes these improvements even more remarkable is that context we talked about earlier.
Which was?
Over the study period, the median number of ED patient visits per month actually rose by 7.3%.
Wow, so demand went up.
Yeah, from nearly 10,900 patients a month to over 11,600. So they achieved greater efficiency while dealing with more patients. That's pretty impressive.
Okay, so let's look at some of those key performance metric improvements. What do they find?
Well, the median time from login to disposition, that's basically the total time a patient spends in the ED, from first registration to getting their final care decision.
The total length of stay, effectively.
Pretty much. That decreased significantly. It dropped from 4.6 hours down to 4.0 hours.
A reduction of 36 minutes on average. That's huge for patients.
It really is. And the study notes this was statistically highly significant, p-win less than 0.001, meaning it's extremely unlikely these improvements happened just by chance.
Okay, strong evidence.
It suggests a real, measurable impact from the lean implementation.
That makes the data even more convincing. What else improved?
They also saw the median time from logging to triage, how long you wait just to be initially assessed, decrease from 0.6 hours to 0.3 hours.
So cut in half from about 36 minutes down to 18 minutes.
Exactly. An 18-minute reduction right at the start. And the median time from login to actually seeing a provider fell from 2.1 hours down to 1.6 hours.
That's another 30 minutes shaved off. These are substantial gains when you're talking about emergency care.
Definitely. And on top of that, provider productivity, measured as patients seen per hour, improved by 18.8% in the first quarter of 2011 compared to their baseline.
Almost 19% more productive, and that was statistically significant too.
Yep, P equals 0.02. So another strong indicator.
And importantly, the study makes a point of noting that no major changes to daily staffing levels were carried out during this time.
Right, so they weren't just throwing more people at the problem.
And the way they measured things, the data definitions, remained constant, which adds further weight to these findings, doesn't it?
It does. It helps rule out other explanations. Plus, anecdotally, they mentioned providers also reported significant improvements in their workflow. They felt the difference.
So the numbers and the human experience lined up.
Yeah, which suggests these changes made a real positive difference on the ground.
These numbers clearly illustrate that this kind of systematic process improvement can yield really substantial benefits, even when demand is going up.
It really shows how targeted changes, based on that lean thinking, can create a noticeable inflection point in performance. Now, the study, to its credit, acknowledges limitations.
Like the lack of a control group we mentioned.
Right, an uncontrolled design. And also the potential for a Hawthorne effect, where people perform better just because they know they're being observed or are part of something new.
Sure, that's always possible.
But even with those caveats, the consistency of these improvements across multiple key metrics strongly suggests a positive impact from the lean approach they took.
That's incredibly compelling data. But, implementing something like lean in a dynamic, high-stakes environment like an ED, it can't have been all smooth sailing, right?
Oh, absolutely not. Change is hard.
What are some of those less obvious cultural resistances or, initial friction points that often pop up when you try to apply these factory floor principles to patient care, even in a success story like this?
That's a critical question because transformation is as much about people and culture as it is about process maps and tools.
Right.
And beyond the numbers, this deep dive offered some invaluable qualitative lessons learned right from the front lines. First and foremost, we touched on executive commitment earlier.
Yeah, the top brass being involved.
And it wasn't just important, the study emphasizes it was absolutely necessary. Visible participation by both hospital and departmental executive committees wasn't just about showing support.
What else did it do?
It actively helped remove barriers that frontline staff might hit. It green-lighted crucial, even if minor, resource reallocations needed for the changes. And generally, it created that environment where staff felt safe enough to actually try new things, maybe fail, and learn.
So it signaled long-term intent, not just another project of the month.
Exactly. Without that deep, visible buy-in from the very top, these changes would have likely struggled to gain real traction. People often wait to see if leadership is truly invested before they commit themselves.
Makes total sense. What about engaging other parts of the hospital? You mentioned the ED doesn't work in isolation.
That was another crucial insight. The importance of external stakeholder commitment. The ED relies heavily on other departments, radiology, the labs, admissions, consulting specialists.
Right, they're all interconnected.
Deeply. So engaging these external departments was absolutely vital for improving processes that cross departmental lines, which many ED flow issues do.
Any examples of where that worked well or maybe didn't?
Yeah, this study gives both a success story. When radiology administrators actively participated in that RIE, focused on ED radiologic exams.
The one that led to the pull system.
Right. That collaboration was key to making that switch happen, including getting dedicated transport staff reassigned. Success.
Where it was tougher.
Well, they highlighted an RIE that tried to address consultant workflow, how quickly specialists responded and communicated back to the ED. That one faced difficulties.
Why?
Primarily because not all the leadership from the various consulting departments were fully engaged in the process.
Inconsistent buy-in from outside.
Exactly. And that resulted in inconsistent adherence to the new communication protocols they tried to set up. It really shows you need everyone who touches the process to be on board right across those organizational silos for comprehensive improvement.
That's a really powerful lesson. But even with all that buy-in from executives and other departments, I can imagine it's still tough to make new ways of doing things stick, especially when things get busy and the pressure's on.
Oh, definitely.
What were the biggest sustainment challenges they faced, making the changes last?
You're absolutely right. Sustainment is often the hardest part of any change initiative. The study candidly notes that staff often reverted back to the old way of doing things.
Especially under pressure, I bet.
Exactly. Particularly night staff, perhaps.
Sure.
Or during periods of really high patient volume. It just underscores that change isn't like flipping a switch. It's a constant effort against ingrained habits, especially when you're stressed.
So how did they combat that? What were the lessons for sustainment?
The study identified 4 key lessons that really helped. 1, clear communication and in-servicing. You can't just announce a change. You have to constantly explain the why and the how, get buy-in, address concerns.
It makes sense. Keep talking about it.
2, strategic timing. They found it best to initiate new processes during off-peak times, maybe quieter shifts, and crucially have the process owners and even executive staff present and visible during the rollout.
Show support during the launch.
All right. 3, inclusive participation. Making sure they included representatives from all shifts, days, evenings, nights, in the actual RIEs.
Why was that so important?
Because conditions, challenges, and even team dynamics can differ significantly across shifts. What works on a Tuesday morning might need tweaking for a Saturday night. You need that diverse input.
Good point. And the fourth lesson.
And perhaps the most powerful one, developing clinical champions and strong mid-level managers.
Champions, people on the ground leading the charge.
Exactly. These were frontline staff nurses, doctors, techs, who really understood and embraced the new workflows, became experts in them. They provided constant guidance and leadership to their peers and were critical in facilitating buy-in from skeptical colleagues.
Like internal influencers.
Pretty much. They were the glue holding the changes together day to day, reinforcing the new habits.
That really drives home that idea of lean transformation being about building a learning organization from within, powered by its own people.
Absolutely. It's about building a culture where improvement is everyone's job, not just management's, and where new methods are continually reinforced, tweaked, and adapted based on real-world experience.
Did they learn anything else about sustainment later on?
Yeah, the study mentions a second value stream analysis they conducted after the first year or so.
Checking back in.
Right.
Yeah.
And that actually reinforced some of these lessons. It highlighted the need for even more mid-level managers and champions to support the changes long-term. And it also pointed to the necessity for greater engagement with inpatient services, the wards upstairs, to really address the bottlenecks caused by admitted ED patients waiting for beds.
The infamous ED boarding issue.
Exactly. It showed the next frontier for improvement was beyond the ED's walls. They also learned a bit about maybe initially setting some lofty or incompletely validated standards and the real importance of having robust ways to actually capture data for any new metrics you introduce. It shows that continuous learning applies even to the process of improvement itself.
Fascinating. Now, what adds an even more compelling layer to this whole story is the context we touched on briefly earlier. This transformation happened in a safety net public hospital.
Right.
This isn't just any well-funded private hospital. That environment adds unique layers of complexity, doesn't it?
It absolutely does. And the study is very clear about the significant resource and patient population-related constraints that made this achievement even more impactful.
What kind of constraints are we talking about?
Well, for instance, revenue expansion is often blunted, as the study puts it.
Blunted, meaning?
Meaning because they serve a predominantly self-pay and publicly insured Medicaid, Medicare patient population, their ability to generate extra revenue to invest in, say, major capital projects or significant staffing increases is pretty limited compared to hospitals with more privately insured patients.
Okay, tighter budgets.
Definitely. Then you often have strong union agreements in public hospitals. These can sometimes complicate implementing new employee work responsibilities or certain kinds of performance-based incentives. It requires careful negotiation and collaboration.
Adds another layer of complexity to changing rules.
It can. And finally, just basic culture change itself can sometimes be more difficult, especially in institutions with many long-tenured employees who are, understandably, used to doing things a certain way for a long time.
So resource limits, workforce structures, established culture.
Yeah, these are all significant hurdles that make this lean success story in a safety net setting even more remarkable, I think.
This context is just so crucial, isn't it? Achieving these kinds of measurable improvements, shaving half an hour off wait times, increasing productivity in an environment that's inherently constrained by resources, dealing with incredibly diverse and often complex patient needs, and navigating established workforce structures.
It really makes the systematic approach they took and the lessons they learned about commitment and sustainment even more valuable.
It truly demonstrates the maybe surprising universal applicability of these lean principles, even in the most challenging settings.
Exactly. It proves that with the right methodology, strong leadership commitment, and that crucial frontline engagement, significant improvements are possible, perhaps even where they might seem most out of reach.
So wrapping this up, what does this all mean for you listening in? This deep dive into a busy New York City emergency department really shows us the profound promise of applying lean methodologies in healthcare.
It's not just theory.
No, it's a testament to how a structured, systematic approach, one relentlessly focused on removing waste and optimizing the entire patient experience, can lead to very real, tangible improvements in core metrics. Things like total length of stay, patient flow, provider productivity, things that matter to patients and staff.
Yeah, the numbers speak for themselves.
They do. And it also leaves us with those critical takeaways that honestly extend far beyond hospital walls. That indispensable role of visible executive commitment and engaging external stakeholders.
Can't do it alone.
No. And those practical strategies for actually sustaining the new workflows. Clear communication, strategic timing for rollouts, inclusive participation from everyone involved, and empowering those invaluable clinical champions who really drive the change from the front lines.
It highlights that successful transformation is as much about the people and the culture as it is about the processes themselves. Engaging every level, especially those on the front lines, is just pivotal for making changes stick long term. It's about building that learning, adapting organization.
Definitely.
This deep dive really makes you consider beyond just healthcare, where else? Where else in your daily life or maybe within organizations you're part of could a similar systematic approach, identifying and eliminating that waste, that muta, lead to profound improvements, even when conditions are challenging?
Applying lean thinking more broadly.
Yeah. How much you apply some of these principles focusing on value, smoothing flow, empowering people to create better value and smoother experiences in your own world. Something to think about.
That's a great final thought. Thanks for joining us for this deep dive. We hope it gave you some powerful food for thought.